And now I would like to pass the presentation over to Deb. Take it away, Deb.
Thank you, Clara, and thanks everybody for joining us tonight. Happy HPP Awareness Day. I can't think of a better way to raise awareness and to talk about HPP than what we're doing right now on this webinar, and especially to be joined by Dr. Simmons and Dahir from Vanderbilt to talk about such an important topic, HPP assembling and coordinating your personal care team. But before we get started, I wanted to start by talking a little bit about Softbones for those of you who may not be familiar with us or who are new to the organization. We are a nonprofit patient advocacy group, and as you can see, here are some images from some of our past meetings that we've had. And we have a mission that is to provide valuable information, education, and support for people living with hypophosphatasia, their families, and caregivers. The foundation also promotes research of this rare bone disease through awareness and education. And really, it boils down to three things that we do. We power the HPP community through events like this, education, patient meetings, and such. We provide grants and we foster research. We support policy and access initiatives to make sure that people have not just access to potential therapy, but access to providers and physicians and healthcare providers that have experience with HPP, and that can be across the spectrum of different specialties, which is some of what we're going to talk about today. And then we connect people through our Facebook page, through social media, through our patient meetings, and then also through a new website that'll be launched through the end of the year with a special new community platform that's going to be really exciting. We believe a cure is possible in our lifetime, and one of our big initiatives and priorities is pushing for new therapies, really understanding the current therapy, who is right for that particular therapy, so we can understand the unmet need and articulate that to other researchers and try to foster additional research so that there can be new treatments available for those who have that unmet need. And that's through some of the exciting advances that you hear about in gene editing and gene therapy. And we are constantly, in fact, I went to a webinar on that today, learning more about these new potential technologies and how HPP may fit into that research paradigm. And then as part of that, we have an HPP patient registry, and we'll talk a little bit more about that in a minute. But we need your help to unlock the key to HPP. As you know, and many of you have experienced, this can be a very serious condition, and we welcome your treasure, your time, or your talent to help make our foundation a success. So anything that you can do to get involved, we welcome the help and support. We've recently started to provide regional support. So in addition to a national patient meeting, we have basically divided up the U.S. into 8 different regions, and we have region leads in each region and meetings that are happening in each one of those regions. And it's been a really successful initiative. We're getting more and more traction, and I think it's really terrific for people to meet with people in their own communities and their own areas of the country. And this is also going to parlay really well into some of the policy initiatives that we're going to be looking toward in 2020. So stay tuned and make sure that you get involved with your region meeting. If you don't know who your region lead is or don't know when those meetings are, let us know so that we can make sure that we connect you with your region lead. Oops, I went too fast. Our registry, as I mentioned earlier, super important. There's been some, probably about 3 or 4 research initiatives that have gone through our registry so far. We have 200 people enrolled, but that's a fraction of the people that we know who have HPP in our patient community. So I still continue to urge people to go to the website, go to our Softbones website and look for the link to the region, to the registry, and make sure that the people who who have a diagnosis of HPP are in there, but also any carriers. We're also trying to better understand what it means to have a single mutation, and if you start to exhibit symptoms, what that means from a treatment perspective and managing those symptoms. So if you're not in the registry, make sure you're in there. And it's a global registry, so anyone anywhere around the world can join. And finally, I can get my slide to advance. Clara, can you advance it? For some reason, it's not advancing. There we go. So with that, I'm going to pass it over to Drs. Simmons and Dahir. I'm going to tell you a little bit about them first. Many of you know Dr. Dahir. She received her undergraduate degree from the University of Virginia. She completed medical school at East Virginia Medical School and completed her internal medicine residency training at Vanderbilt University Medical Center. She then pursued a fellowship in diabetes, endocrinology, and metabolism at Vanderbilt University Medical Center. She's a professor of medicine in the Division of Endocrinology and Metabolism at the Vanderbilt University Medical Center, and she's the founder and the course director for the Endocrine and Rheumatology Metabolic Bone Fellows Conference. She's also been a recipient of our Soft Bones Research Grant and one of our treasured partners. Dr. Simmons is a professor of pediatrics at the Ian Burr Division of Pediatric Endocrinology and Diabetes at Vanderbilt University Medical Center. She graduated from the University of Tennessee College of Medicine, and she completed her pediatric residency and fellowship in pediatric endocrinology and diabetes at the University of Colorado Children's Hospital and Barbara Davis Center for Childhood Diabetes. She joined the faculty at Vanderbilt University Medical Center in 2006, and she's the founder and director of the Vanderbilt Program for Pediatric Metabolic Bone Disease, and the founder and chair of the Hazinski Society for Faculty Development, and the director for faculty mentorship programs at Vanderbilt University. So please join me in welcoming Dr. Dahir and Dr. Simmons. And Dr. Dahir, I'm going to pass it over to you.
Oh, Deb, thank you so much for that lovely introduction. And I also want to start off by just saying thank you. Thank you so much, Deb, for this invitation. And I also want to thank Denise Goodbar and everybody from the Soft Bones family who has been so lovely and so kind to us at Vanderbilt. So I know I'm speaking for Jill as well, that we're really honored to have this opportunity. And what we're going to be talking about today, hypophosphatasia, assembling and coordinating your personal care team. And what's been really interesting about learning about HPP over the last decade is just how much we've learned over the last decade. I just think I met my first patient with HPP probably 10 to 15 years ago, and at that time, there was so little in the medical literature. There was maybe one paragraph in the metabolic bone primer, and now there is just a huge volume of work that's out there that's growing over leaps and bounds. And one of the many things that I've learned is just how different everybody with HPP is. Everybody needs kind of their own personalized care team because everybody is so different. So that's what we're going to be talking about today. Okay, if I can get my slides to advance. There we go. Okay, great. Just a little housekeeping. I am a clinical trial investigator and do work as a consultant for other rare metabolic bone diseases, likewise for Dr. Simmons. Okay, so our agenda today, I'm going to go over a 30,000-foot overview of the importance of genetics and what a genetic disease and how it relates to hypophosphatasia. Dr. Simmons is going to pick up at that point, and she is going to go over the brass tacks of the diagnosis and signs and symptoms of hypophosphatasia. And then we're going to talk about building your team and your coordination of care between specialists and what specialists that you might need or you might not need. So the definition of hypophosphatasia, or HPP, which I'm going to say now because it's a lot easier to say, but it's a genetic change that leads to problems with bone formation. It can lead to muscle pain and weakness and early tooth loss. The specific gene that we're going to talk about today is called the Alpl gene, and it's responsible for the body's production of an enzyme called alkaline phosphatase. And to get more specific, it's tissue, non-specific alkaline phosphatase, so it's in really all parts of our body. And a change in this gene leads to a deficiency of this enzyme, and we're going to talk more about what that means. So just some basic overview about the genetics of HPP. And this is going to be a little bit of a flashback from high school biology, but I think it's really important to understand the vocabulary if you have a genetic disease, because that really opens a lot of communication between you and your doctors and your other partners in your care. So kind of the basics of DNA. So traits are determined by genes on chromosomes. And what a trait is, it's a characteristic or a feature. So you have red hair, or you have black hair, or blue eyes, or green eyes. And they're determined by genes. And genes are a set of instructions that we have in our body that tell certain parts of our bodies to make a protein or to do a particular action. And these recipes or instructions are warehoused in what's called chromosomes. So a gene is a segment of DNA that determines the traits. And so when we see if my pointer can work here. Oh, shoot. Sorry, guys. Okay, so here is a human baby. And humans, we're made of about 50 trillion cells. So that's lots of teeny tiny little working pieces of our anatomy. And there are certain cells that are predestined to become different types of organs. So we have cells that will become a brain cell or a heart cell or a red blood cell. And so how do our cells know what to become and what type of protein to make? And that's because each individual cell has a set of instructions. And if you go over to the right and you look at this cartoon of a cell, there's the part of the cell in the middle, that's called the nucleus. And that's where we warehouse all of our DNA and all of our genes. And believe it or not, each cell contains 20,000 genes. So that's 20,000 separate recipes that are instructing our cells of what to do. And if you took all of our genes and all of our DNA and you stretched it out into a long strand, it's 6 feet. And that 6 feet of instructions fits in these teeny tiny microscopic cells. And I think that's incredible. And the way that we're able to do that, these pieces of our genetic material are so tightly wrapped and coiled together that they fit in these teeny microscopic areas. And they're organized into these things called chromosomes. So if you go farther over to the right, we see this thing that looks like an X. And when you unravel it, that's when we get our strands of our DNA, our genetic code. And what it looks like a ladder, and the outside of the ladder is made of phosphorus and glucose, and the rungs are our DNA, our code for our DNA, and those are base pairs. So we have a base pair of cytosine, which always pairs with guanine, and then adenine always pairs with thymine. And the way that those are lined up is really very similar to computer code, and that's how those are our instructions. And so these specific instructions goes back to the cell to tell it what to do. And now every single cell doesn't have all 20,000 genes working at once. We have different switches in our cells that turn on only these pieces of DNA that we need. And that really, that's what our DNA is. And the other thing that's really fascinating about DNA is, as humans, we look at one another and we think we're so different, but genetically speaking, we're so similar. So if we stretched out all of our DNA, 99.5% of our DNA from person to person to person is exactly the same. And we're actually pretty similar to other animals too. So there's only a 1% difference between us and primates, which I think is pretty fascinating. And so of that 0.5%, what is it that makes us different? And those are variations in our genetic code. And so why do we have variations in our code? Why are all of us as humans a little bit different? And that's because cells don't live forever. We don't want our cells to live forever, right? Because then that's a cancer cell. So cells constantly have to divide and replicate themselves. And when they do that, they have to replicate all of that DNA, all of those base pairs, all of that computer code. And what happens, thinking about what would happen if we were doing this on a typewriter, we would make typos. And those typos get passed down generations to generations to generations. And those are called SNPs, or single nucleotide polymorphisms. And we have in humans about 10,000 of these SNPs in our bodies that don't change the protein. They're not in areas which are important for DNA coding, but that's what makes us unique, which I think is really interesting. And that's also, if we are looking at people's DNA, we can figure out how related we are to other people, and that looking at these polymorphisms that are passed down in families and in communities, that's how we can see we're related. So if any of you have done 23andMe or Ancestry.com, it's just that process of looking for these variations in our DNA. Now, sometimes when we make a typo, when we're replicating our DNA, it might be in a really important and critical area in a gene. And if that recipe or that instruction gets dysregulated because it changes the protein, then that's when it leads to disease. Okay, so chromosomes. These are really important. So I had told you that in our DNA, in our genes, we have 20,000 genes, 6 feet of DNA that gets wrapped up really tightly and segregated into different chromosomes. So we can take somebody's cell and get into the nucleus, and we can take out their DNA and we can see how they group together. And so what's important to know about chromosomes, you see that we have 23 pairs, and we get one set from mom and one set from dad. And for our pairs of chromosomes 1 through 22, they're pretty identical. Except for the 23rd set, we get, those are our sex chromosomes, so we get an X from mom, and which is going to code for making a female, and a Y from dad, that is going to code for a male. So 2 X's, you're a girl. If you have a Y in there, you're going to be a boy. So those genes are a little bit different. So where does the Hpp gene fit in on our chromosomes? And it's on chromosome 1. In case you were wondering. And you can see that on chromosome 1, we get 1 copy from mom and 1 copy from dad. So if we look a little closer, if we stretch out chromosome 1, we actually know exactly where that Alpl gene is. It's on the short arm of chromosome 1 where that yellow arrow is, and we know it's a pretty small gene that's pretty close to the end. So when we look at in more detail about different gene changes that folks with HPP can have, it can be really anywhere along that chromosome. Now, there are what's called exons, and that's the part of that gene that's important for those instructions. We have areas that are called introns that get spliced out. And so usually changes in the exon leads to more consequences of the protein that's made. You can see that just one tiny change in one base pair, that's called a missense mutation or a point mutation. That teeny change is enough to cause HPP. And most of those changes can be anywhere in the second exon all the way to 12. Now, there's a database that keeps track of all of these different gene changes that have been associated with the Alpl gene. I looked at that database in the last few weeks. It was over 360 gene changes, and that's growing by the day. And so occasionally people will have different types of changes in the gene. It's just not one base pair that's swapped out for another. Sometimes people are missing a part of the gene, or they can have an extra part of the gene that's in there. Sometimes there can be a change in the regulatory region. So again, everybody is a little bit different. There's lots of different variations in the changes that we see in this particular gene. Okay, inheritance patterns. And so I think this is really important because we see different types of inheritance patterns in patients who have HPP. Now, what autosomal recessive means, and that's that top cartoon up there, means you have to get the change in the gene from both your mom and your dad. And those tend to be obviously a lot more rare, and there's more of an effect on the protein, and so the presentation of the disease tends to be more severe. But we're also seeing autosomal dominant and in the same families as well, and that means you can get it from mom or dad, but not both. And it's not necessarily you have 50% of the disease. I wish genetics were black and white like that, but it isn't. And the big, take-home point there is that it's good to take a look around in the family when you're screening for other people that might have HPP, because there can be both forms of both autosomal recessive and autosomal dominant, which means you can have one affected gene or two affected genes in the same family. And just a little bit of terminology. Under autosomal recessive, there's a term called compound heterozygotes. And really what that means is that this is for somebody who has a gene from mom and dad, but the point mutation may be in a different place in the gene. So the changes in the gene, in the ALPL gene, may be different each from mom and dad, but it still causes an autosomal recessive pattern. We don't get HPP through the X chromosome. You may be hearing more about X-linked diseases, for example, X-linked hypophosphatemic rickets, which has a lot of similarities to HPP, but that comes from the X chromosome. It's different than that. And HPP does not come from mitochondrial DNA, which is a type of DNA that you just get from your mom. And then another really important thing that, we like to say, and I like to tell patients that genetics is not black and white. It can be very mushy. And that HPP can be affected by other genes as well. So people can have other genes that might make HPP worse, or it might protect you from having a more severe form of HPP. And this is something that we're really thinking about and learning more about the effects of other genes on patients that have HPP. Okay, I thought I would throw in a pedigree in case any of you have seen your doctor or your geneticist draw out a pedigree, but this is what it looks like. The circles are for females and the squares are for the males, and you can see the line going from mom and dad down to their children. And if someone has a particular disease or trait, we tend to color that in. I think drawing pedigrees is a really important part of our job, so we can do a lot of family counseling. And so just to kind of hit both of those points that I just talked about, here is a pedigree of a family with hypophosphatasia that has both autosomal dominant and autosomal recessive, and possibly people who have the gene and are just carriers. The first diagnosed person in this family was an infant with HPP, but when you go back up through the family tree and you see parents that have just one gene, some have no symptoms, some have mild symptoms, and some have symptoms that are more severe. So this is what kind of a typical HPP pedigree looks like. Okay, genetic testing, pros and cons. And before we do genetic testing, we like to make sure you know what you're getting yourself into. Not everybody wants to have genetic testing done. And there are reasons to do it, and there are reasons to think about maybe that's not something that's your cup of tea. The reason why we advocate for genetic testing, there are lots of reasons. One, we can identify family members at risk. So if there's one person in your family with HPP, and it makes a lot of sense to identify other people because there's early intervention and identification. Typically, when we're doing additional genetic testing on family members, it's not as expensive because we know exactly what gene we're looking at. We don't have to look at the entire gene. And then early diagnosis and intervention, but also confirmation of the diagnosis, and I think that's important. You know, when I think about how do we diagnose people with hypophosphatasia, that's not really an easy answer. Because you have to have symptoms, you have to have biochemistry, in addition to having the gene. So it's really a trifecta of lots of different things to think about. And for cases that we're not 100% sure, sometimes it can help us think, is this HPP or is this not HPP? So in that setting, genetic testing can sometimes be helpful. So what are the cons to getting genetic testing? Well, some people just don't want to know. Sometimes we get genetic testing back and we're confused by those results. And one of the issues are these variants of uncertain significance. And we certainly see that a lot. And what that means when we get a variant back is that it's not been reported in other patients to having caused disease. And then we have to think about looking at where that change in the DNA is, how it affects production of the protein, and does that make sense that that change would cause any problems? So that's a really gray area. Then here's one that I really think is very important to think about. Feelings of guilt is passed on to the younger generation. So that is something that we're all very sensitive about. Because oftentimes people don't get diagnosed with HPP until after they've had their children. And so what does that mean if you get confirmation of a test that you have the gene and you may have passed it on to your children? And that's something that you really need to think carefully about, maybe even get some counseling about, and how are you going to handle that information if you get it? Certainly what we don't want to do for this next point here is do genetic testing and take somebody who doesn't have any symptoms and may be a carrier and then make them feel like they're a patient. We don't want to give somebody the burden of a label or a diagnosis if just having that gene change is never going to cause any problems. And again, I think people are worried about how is it going to affect my job, how is it going to affect my insurance. So these are things to really think about carefully before you just dive in. Okay, the variant classification system, I'm throwing this in here because I find that a lot of my patients, they like to take a look at their genetics report and understand it, and the classification system is really not all that clear. And I'll tell you, not all doctors understand how to interpret these reports. And so we go from class 1 to class 5. Class 1, benign, meaning no symptoms. That's very reassuring. Likely benign, you know, there may be some theoretical risk that the change in the gene might lead to a change in the protein. Typically the ones that are benign, you can have these changes in your base pair, but they don't even affect changing of the protein at all. The variants of uncertain clinical significance, those really do require a lot of careful thought because we can't really tell you yes, no, or otherwise we know what this means. It's going to require additional testing to put all those different tests in the aggregate and try and make sense of, is this gene really causing your symptoms or not? Then there's likely pathogenic, and then pathogenic is based upon a pretty complicated criteria of genetic changes and what's already been reported in the medical literature. And then to make it even further complicated is that classifications of gene mutations sometimes change over time. And so somebody may have had genetic testing 10 years ago, and if it would have gotten a different classification 10 years, say there's more in the medical literature, or that that patient's family history that would support that this is a disease-causing variant. So again, I just throw that out there to say that this classification is very much a moving target. It's only a small piece of the information. There's so much that's more important or as equally as important of your medical history, your what's going on in your x-rays, etc. Again, just a small piece of the information there. Okay, my slide here, don't forget your family members for anyone that has a genetic disease, to always kind of look up, down, and sideways in your family tree for early intervention and diagnosis. And again, just kind of another typical pedigree of family with HPP. Okay, and on that, I am going to turn the microphone over to Dr. Simmons.
Hi, thank you, and thanks everybody for your attention tonight. Kathryn, that was wonderful. And what I'm going to do is talk to you guys a little bit about how we think about HPP, how we make the diagnosis, as well as perhaps some signs and symptoms that we will find that our patients have. So here we go. Okay, so that being said, Kathryn did a nice review of genetics, and what I would like to do is talk to you a little bit about what does the alkaline phosphatase actually do? And this is a very simple cartoon of what we call bone remodeling. And so if you think about bones, I think we all intuitively know that our bones are constantly going through what we call a remodeling process. And that, of course, is how we can do things like heal bones after a fracture. But there's always an active remodeling process going on, even if there's not a fracture. And unfortunately, that remodeling is affected in patients with hypophosphatasia. And if you look at this little almost, this is called an osteoclast. And an osteoclast, we always think of as kind of the Pac-Man of the bone cells. And an osteoclast will sort of go through and eat away the previous bone. And then an osteoblast will help, is a different bone cell, and it will help to lay down new bone and promote that bone healing as well as new bone production. And unfortunately, alkaline phosphatase is a really key enzyme in that process. And so if we don't have alkaline phosphatase, we don't have good bone formation, and that can lead then to bone fragility. So that's sort of a simplistic picture of what's happening within the bone in patients with hypophosphatasia. And this is a little bit more theoretical. So many people complain quite a bit about generalized muscle ache and muscle weakness, and I think that there's still a lot of information that we don't know about this, but sort of the going theory is that the lack of alkaline phosphatase in the muscle will lead to an increase in something called pyrophosphate. And pyrophosphate is then broken down by alkaline phosphatase into phosphorus. But if you don't have alkaline phosphatase, then it builds up. And the thought is that that buildup of alkaline phosphatase in the muscle tissue may be the source of pain and muscle weakness. Unfortunately, we don't really have muscle biopsies to really verify this, but this is sort of the going theory. And then what about the teeth? As many of you know, one of the presenting symptoms of HPP is early tooth loss. And you'll see here a picture of a couple of teeth that you know, don't look like the classic teeth that you lose when you lose your baby teeth, right? So when people say the roots are intact, they're describing this look to the tooth itself. And the reason for that is that alkaline phosphatase is required for cementum itself to form on the roots of the tooth. And without that cementum, the teeth are not appropriately lodged into the jaw and can essentially get loose and sort of slide out. And this is often painless, of course, and there's often little to no bleeding, and can happen it can happen at any age, of course. As a pediatrician, what I tend to see is this type of tooth loss can occur even in infancy. So any time prior to the age of 5, we think that that's concerning. Excuse me, the age of 4, we think that that's concerning. But obviously, a tooth that comes out like that at any age is concerning. The truth is we don't really know how common hypophosphatasia is. We get asked this a lot, and we have to go by the literature, and the literature says it's thought to occur as frequently as 1 in 6,400 people in its quote-unquote mild form, and in our more severe forms, probably more like 1 in 300,000 patients. But we think in a lot of cases it's been very commonly misdiagnosed, certainly in the past. I think that's getting better and better as the years are going by, and as Dr. Dahir mentioned, as we're gaining more and more information, I think the awareness of this disorder has really increased in large part due to the work by Softbones. And as people are recognizing this disorder, then doctors are becoming more aware of it and more appropriately making the diagnosis. And so, how common this is or is not completely clear. To give you a little idea of what's happening at the bone, you may hear the term rickets. You may hear the term osteomalacia, and I just want to kind of explain what that means. So the truth of the matter is that rickets only occurs in growing bones. So we only see this in pediatric patients, generally before the age of, really well into puberty, so those true childhood years. And this is a wrist. And what you'll see here is the end of the bones of the forearm, so the radius and the ulna, are nice and smooth, and this is a really normal x-ray. But a child with hypophosphatasia may have a lot of ruggedness to the end of those bones, and some people even describe that as a moss-eaten approach, like they're sort of being eaten away. And again, that's because the remodeling process is not normal, the mineralization is not normal without the alkaline phosphatase, and so the bones are not appropriately mineralizing as a child grows. Now, patients at all ages may have what we call osteomalacia. And osteomalacia is something we would see if we actually took a piece of the bone in a surgery for HAPS. We call this a bone biopsy, or maybe if a surgeon's doing a procedure for other reasons, they may give us a little sliver of the bone, and we can look at it under the microscope. And what we're looking at is sort of what the bone structure it looks like itself. And here you'll see a slide of a normal bone, and this green here is the mineralized bone tissue. And this little thin red area is what we call osteoid. And osteoid is sort of the precursor to bone tissue, and as osteoid gets mineralized, it becomes regular bone. The patients with osteomalacia, and I have to apologize, this arrow was in the wrong place. You see how big this area is of unmineralized bone and how wide it is here. That's what we call osteomalacia. And so again, there's a problem with the mineralization, and we see this in patients of all ages with hypophosphatasia. HPP, though, does affect more than just bones in some patients. And without belaboring this to too much extent, we can sometimes see neurologic signs. Those very classically are seizures that we may see in our most severe patients, but there's definitely some concern in the literature that perhaps migraines and other ADHD and other sorts of what we would classically think of as neurologic symptoms may perhaps be related to hypophosphatasia. Again, we talked a little bit about muscle weakness and muscle pain. Respiratory effects really primarily are just occurring in our youngest patients, in our infants and our babies, excuse me, our perinates in our infants who may not have normally formed ribs while they're in utero. Patients may have renal problems due to increased calcium as part of the process of the disease that may cause calcium buildup in the kidneys. Again, relatively uncommon in more of the typical adult forms. And my last thing is not poking up here, but rheumatologic problems may occur as well. There we go. And those may be joint pains due to calcifications that can occur within the joints. Okay, so classically we have defined hypophosphatasia by the time in your life at which you initially have symptoms. I will tell you that there is a huge drive to get away from this, and I think it's important to consider that possibility. Because in classical form, we've always thought, okay, the earlier you present, the more severe your disease, and the older you are, the less severe your disease. But it turns out that's not necessarily the case, and that people who may really look back at their childhood and truly not have symptoms until they're adults still may have very significant disease. And so, you know, when you read about it in the literature, you're going to find these sort of cutoffs of perinatal occurring, you know, either in utero or at birth, an infantile presentation occurring prior to age 6 months, childhood form occurring after 6 months but before age 18 years, and the adult form happening after age 18 years. But there's certainly a drive within this field that maybe we need to really rethink this and call this more mild, moderate, and severe. Because as Dr. Dahir just pointed out, this is a genetic disorder, which inherently means you've always had it your entire life. And so defining it as adult HPP doesn't always make a lot of sense if you're thinking about a genetic disorder. That being said, very briefly, because we want to get to truly what I think people are excited about, which is how we build the care team, I want to just briefly talk through what these terminologies mean. So perinatal hypophosphatasia, again, presenting at birth or in utero, historically was thought to really be a lethal disorder. Fortunately, that is changing with the advent of medical therapy over the last 5 to 10 years. But these babies are often really, really sick. They often have significant seizures. They have significant respiratory problems that require intensive ICU management. Babies who have infantile hypophosphatasia present after birth, but less than 6 months of age. They often have difficulty with feeding, poor weight gain. They may have delays in their motor skills, which may look like slowness in walking, crawling, pulling up, those kinds of things. They may have what we call craniosynostosis, which is a big, long, fancy medical term that really means early fusion or partial fusion of those fontanelles. And of course, the fontanelles occur in a baby so that a baby's skull can continue to grow as they grow. And if those suture lines in the skull actually fuse too early, then the skull cannot grow normally, and that may actually lead to requirement for surgical manipulation of the skull, which obviously is a big deal. These babies may have progressive demineralization of the bones. They too may have some seizures, and they may have respiratory distress. What we've traditionally called childhood HPP has really quite a wide spectrum of severity. Kids that I've seen may present to me with early tooth loss, as was just described. They may have minimal, if even, and maybe even no skeletal changes. They may have really normal-looking physical exams. They may also have some bowing or maybe some rib abnormalities, as is pointed out on that slide. And when we do a good, thorough physical therapy examination, they may have muscle strength that appears normal in everyday life, but may actually be identified as being in the lower half of age norms when we really look closely. Or these kids may be a lot more severe with pretty significant skeletal mineralization problems, muscle weakness, lots of complaint of pain or difficulty keeping up with the other kids in their, on the playground or in their neighborhood. They may also have some abnormal skull shapes due to that early closure of the fontanelles that we just discussed. And then as the theme that hopefully you're getting is that the presentation may be very variable regardless of your age. So adult HPP is sort of characterized by bone biopsy as osteomalacia. How that may identify itself is kind of characteristically, people may have metatarsal, which are the little bones in the foot, stress fractures that may be recurrent, may be slow to heal. People may have what's called a femoral pseudofracture, which you can see in this X-ray here. You can sort of see this crack. So obviously the femur isn't broken all the way through, but that is certainly not a normal bone. And other types of atypical fractures. Lots of adults have pretty significant pain and weakness. They may need mobility devices, even all the way to wheelchairs at relatively young ages. They may have pseudogout, which is really just a formation of calcifications in the joints that can be painful and can affect mobility and other functional status. And they may also have early loss or requirement for extraction of teeth. So these are some more x-rays. Again, here's a metatarsal stress fracture that we just talked about. So again, this is the little foot bone, and then an atypical femur fracture. And again, we already talked about the tooth loss. So for time, we'll just skip past that. So from a physician perspective, how to diagnose HPP, as Kathryn described, this is not as easy as it seems because there's so many nuances and so many variable presentations and variable severity of presentations. So we as physicians need to really be taking a good, careful medical history. We need to ask our patients, even all the way back into childhood, did they have inappropriate tooth loss? Have they had pain or muscle weakness? Have they had fractures? Asking about family history. Labs, we need to know what the alkaline phosphatase levels are, and the key point of this is that these need to be age adjusted. So during the growing years, if you think about it, when you're growing the most rapidly, you have the most rapid bone remodeling process. So the alkaline phosphatase levels are the highest during those time periods. Those tend to be the first few years of infancy and toddlerhood, and then again during puberty. Those levels then go back down to adult levels after a child has completed growth. But those alkaline phosphatase levels may rise again with chronic illness. They may rise again with a fracture. And so sometimes we find patients with HPP who actually have apparently normal alkaline phosphatase levels if we catch them kind of at one of those time periods. Elevated vitamin B6 may also be or should typically be present in HPP, but it's really important that your doctor check those when you're not on any vitamin supplementation, and ideally have actually been fasting. And the reason for the elevated vitamin B6 is it's another part of the job of alkaline phosphatase is actually to break down B6. And so if you think about it, I always define it as sort of, or describe it to patients as, if you think about a traffic jam, if something is sort of stopping your way in the road, traffic always is going to back up on the other side of that traffic jam. And that's kind of what happens in the vitamin B6 pathway is if there's a problem like a lack of alkaline phosphatase in the breakdown of vitamin B6, you're going to have a higher level of that B6 level. And then we talked a little bit about genetics. So again, this is just a reminder that labs should have age and sex-adjusted normal range. And again, we're just going to kind of skip through that. And I am now going to give this back to Dr. Dahir, who's going to talk about how we sort of bring all this together, all this variability in the multitude of symptoms really can't and probably shouldn't be managed by just one type of doctor. And so we'd like to talk to you sort of about what we have at Vanderbilt, but also about how you can assemble your own care team wherever you are. So.
Great, thank you, Jill. Yeah, so we like to say the management of HPP, it takes a village. And again, variability of signs and symptoms. Everybody is so different. Even within the same family, we see that family members are very different. And also the signs and symptoms of the disease may change over time. So it's a moving target as well. So lots of assessments are required to understand the patient needs. And so I think that's very important when you first get diagnosed to really understand what are your signs and symptoms. And sometimes we see patients have fractures that they don't know about, or they have muscle weakness that they don't know about. So it's good to have a very comprehensive assessment from the get-go. You know, it really is a challenge to measure impairments. You know, the tools that we have looking at motor function, especially in adults, it's really challenging. You know, we have adopted this 6-minute walk test, which was originally designed for patients with COPD. And it's a little tricky to do a 6-minute walk test for people who can't walk, or, you know, if you're in a wheelchair or using an assistive walk device or a cane, or maybe you've come in and you're having a lot of fatigue because you've just, spent 4 hours traveling to your doctor. So that might not be the best and most accurate way to measure motor function. And I think this is a growing field where we're really trying to understand better what are the disabilities and how do they change over time and how do we accurately measure those. So I wish I had a good answer for you on that today, but certainly that's something that everybody is thinking about. Another challenge is with any inherited disease, when we meet our first patient, we may be meeting their child, their mother, their grandmother, and so oftentimes we need to think about multiple members of the family. And then also what's really important is as our pediatric patients grow up, how do we thoughtfully transition them to an internist or to an adult practice? And there are certainly a lot of issues about transition from pediatric to adults. And then every institution that you go to is going to have a little bit of different superpowers that we like to say, different experience, and there's probably not one perfect institution that has it all, but we can certainly try and do our best wherever you are. Okay, just a little bit about the variability, and Dr. Simmons did a great job of going through all of the multi-system consequences that can come from HPP, and we really see such a wide spectrum. So just as an example of somebody who might have adult HPP, we've seen patients with alkaline phosphatase levels that are undetectable. They're wheelchair they're dependent on a wheelchair and have severe skeletal stigmata or changes. And this adult with HPP, you can see there's severe scoliosis, which leads to breathing problems, and osteonecrosis of the jaw, which leads to oral surgery problems. And so really you would think about all the different types of specialists somebody with severe disease might need. And then we can compare it to somebody who's a little bit older and essentially just has early dental loss and some foot fractures, but is able to run on a track and have a full-time job. And there, with some minor fractures here and there, that these two patients, although they have the exact same gene mutation, can present very differently and have very different requirements of their care team. And so that's why we say one size does not fit all. And once we realize what their baseline needs are, that can help us figure out what specialists that they might need to see. And I have to give Dr. Simmons credit for this slide. This picture is my favorite slide in the whole slide deck. So I think that does that justice. So back to the slide that Dr. Simmons shows. So when we think about, again, what specialists you might see, if you've never had a seizure or you don't have headaches or gait instability, you really don't need to see a neurologist. Or, likewise, you probably don't need to see a rheumatologist if you're not having a lot of joint problems. But if your primary manifestation is pseudo-gout and pyrophosphate deposition, that might be the #1 person on your team. Likewise, with seeing a nephrologist, if you've never had a history of kidney stones, but yet sometimes we see patients where their primary presentation is very high phosphorus levels in kidney stones, and that might be their #1 caregiver for hypophosphatasia. So we really have to think about what your symptoms are when we're designing your team. Okay, so the assessments, we talked about this. Jill covered most of this in her talk about, getting the appropriate history and physical exam. And you've seen our x-rays and you've seen some of our dental images, and we've talked about motor function testing and gait function. Other things that we may think about, hearing tests. We certainly see patients with hearing loss. Dexa scans, I would say, are very controversial. I would say most of us probably think a Dexa scan does not give us very good information on the bone quality and patients with hypophosphatasia. So that's why there's a question mark there. And bone biopsies are very risky. I don't know that we would necessarily need to put a patient through that if we have a legitimate diagnosis of hypophosphatasia. That can be very invasive and painful and lead to fractures. Okay. So this slide comes from a 2017 monitoring guidelines patient for hypophosphatasia. And I like to put that up there for a couple of points. One is that the patient is in the middle of both of those circles. We have our adults on the left and our children over on the right. And so we like to think, obviously, the patient is the most important person in this scenario here, and how do we surround you with everybody that you need? The thing that I don't like about this image is that you look at it and it looks very overwhelming. And I would think if you have HPP and you go to this paper, you might think, oh my gosh, how could I have a job? I've got to see 17 different specialists. And really what this is meant to show is that we need to help you pick and choose who are the important people that are on your team. And that's really going to go back to what are the symptoms that you really suffer from the most. And it's a little bit different when we think about the type of specialists that adults need versus the type of specialists that children need, because the children who have the infantile form with the more severe disease have a lot of respiratory and pulmonary problems, and that's why we see the pulmonologist and the intensivist, and that's not going to be something for the most part that we're going to need for adults. So when you look at this, I want you to think about picking and choosing which specialist would be appropriate for you, and that you don't necessarily need to see everybody. Okay, so collaboration. So what I like to say is pick your quarterback or your cheerleader. And there are lots of different specialists that have interest in hypophosphatasia. So we see pediatricians and internists and endocrinologists and rheumatologists and orthopedic surgeons and nephrologists. And that's one of the fun things about seeing HPP patients and doing HPP research is as much as the patients are diverse, so are the specialists that are very passionate about HPP. We're all very diverse as well. And so what I like to break into these two categories are the elements that you need to help you manage your HPP that you can probably get anywhere you live. And then other elements that you might not be able to get in your hometown, but you might need to get a referral if you need extra subspecialist care. But really any doctor anywhere should have access to x-ray, to do blood work, to refer you to a physical therapist, to send you to an orthopedic surgeon if you have a fracture. As far as ophthalmology, we like for patients to see an ophthalmologist because there have been some reports of benign calcifications on the cornea. Don't know if this is natural history of the disease versus could this be enzyme replacement therapy. But I don't know that an ophthalmologist is going to be your quarterback for HPP. Dentistry obviously is very important, and to find a dentist that's kind and caring and compassionate, because most people with HPP have had a long history of going to the dentist, which is always a pleasant experience. And there's some wonderful, fabulous, amazing dentists, orthodontists, oral surgeons that have a lot of interest in HPP, so that's great. For somebody who needs specialized physical therapy, like for gait or balance, or someone who needs to be managed in a pain management, or somebody who's interested in more holistic medicine, is interested in acupuncture or that, Eastern medicine, you may have to look outside of your neighborhood. I put telemedicine up there. I think that might be the wave of the future, to have easier access to your doctor that you might not live near. But telemedicine is also important for doctor-to-doctor conferences, because if you have your quarterback at home, it's always easy for them to pick up the phone and ask somebody a question over the phone about, gosh, what should I do with this type of patient? And thankfully, here in the United States, there's lots of research opportunities for patients with hypophosphatasia. Okay, so just quickly, I'm very proud to say that there's a lot of enthusiasm and love for patients with HPP at Vanderbilt, and we have a lot of folks that have a lot of expertise, specifically in pain medicine and orthopedic surgeon. And I'll tell you that this page wasn't always this big, and a lot of times it takes one doctor in one institution to make a friend with somebody in radiology or with somebody in rehab medicine. And the physicians need to develop that relationship with each other to talk about their patients, to be able to refer patients back and forth and to help each other out with patients with complicated multisystemic diseases. So the dream is that a hypophosphatasia core care team should be everywhere. Okay, so in summary, HPP is caused by a variety of alterations in the Alpl gene. HPP can manifest differently in every patient, even within the same family. It's a multisystemic disorder, so it affects different organ systems and different people. And due to this complexity, a personalized care team, typically including various medical disciplines, is needed. So that's it. Thank you so much, and thank you so much for this opportunity.
Great. Thanks so much.
Thank you. Do you want me to go on, Clara?
Yeah, go ahead.
Okay. So we are a little bit over on time, but I did want to just give time for one or two questions that came in, and as always, we will take the questions offline and we'll follow up with you individually if you have submitted them through the portal here. In addition, this webinar will be archived and available on our YouTube channel, so you'll be able to watch it there as well. But one of the questions that came in, Dr. Simmons, I was going to refer this one to you. One of the questions was, I've heard that you're not considered a carrier and that you either have the disease or you don't. Can you explain that?
I'm laughing because that's a huge can of worms. I think the argument is it depends on who you ask. I think one thought process on that is that if you wait long enough and you ask enough questions, that maybe everybody eventually has some symptoms of HPP, but unfortunately, HPP can mimic so many other things. I think it's really a complex question. So we do still classically refer to people as carriers, and I think you heard Dr. Dahir say that. I think there really are a lot of people who probably really don't ever manifest symptoms that are truly HPP, and we would call them carriers, but I do think there are other people who've been characterized as carriers, maybe just because they're in their 30s and by their 50s they may start to have symptoms. And honestly, I would probably defer that to Dr. Dahir, who does take care of adults, and see if she has other thoughts.
No, Jill, I thought that was an excellent answer. Absolutely. And, the only thing that I would add to that is that's why collecting information in these registries is really important, because HPP is such a moving target. So, and there's the soft bones registry that Deb was talking about at the beginning of this talk. And, for somebody who has the gene but no symptoms, I would really encourage them to enroll in such a registry, because we're going to learn so much more going forward.
Great, thank you. I'm just going to do two more quick questions. I know we have a lot here, but these are all related to genetics, so I feel like we can kind of cover them quickly. One of them is about a genetic report and the interpretation on the report. So somebody had submitted a question that they have one pathogenic variant listed and 3 benign. how do you know that the 3 are truly benign? And what's the criteria for that? And would it change if more people who are symptomatic and newly diagnosed have these benign variants also?
Oh, there's such a complicated answer to that. So when you, and like I said, genetics is not black or white. It's very mushy, which is not a very satisfying answer. So typically when there's a report of it being benign, the amino acid change or the base pair change doesn't lead to a change in the protein. But that's not always, occasionally it can dysregulate the protein, even though it doesn't look like it's an amino acid change or a base pair change that's going to change the amino acid sequence. So it's really, really complicated. One of the things that you can see is sometimes you get these genetic reports back and they have 11 benign changes or 10 likely benign, and is it the cumulative effect of all of those? Who knows? I mean, we don't know. And so the best that we can do from looking at these gene reports is try to make sense. And there are models that you can do by inserting that particular gene change into a 3D computer model to see if it changes or unravels the protein. If you are looking at your report, it says in silico modeling, and that's a 3D computer generation. The other way that people can look to see if that gene change is significant is they can create that in that particular gene mutation in a test tube and see how that affects alkaline phosphatase levels. And there are certain scientists that are actually doing that. That's not available for every single gene mutation that's out there. But it's not that simple because there are so many other modifier genes most likely that may also affect it. So may be protective or may make it more serious. So what I think is the most important thing is maybe not to get so hung up 100% on your genetic report, but think of it as a piece of the puzzle. So what is your genetics plus your physical findings plus your labs? What does your family history look like? So it's really taking all of these different elements in aggregate. And the other thing is that, again, back to that original slide, is sometimes these gene changes get reclassified. So that's probably a very long-winded answer, which was very unsatisfying, but that's really the best way I can explain that.
Great. And then the other question that is related to genetics was actually about Ancestry.com. So with all of the 23andMe's and the Ancestry.com, available genetic screenings that they have out there, they don't necessarily look at the entire ALPL gene. Are the parts of the gene they look at for single nucleotide polymorphisms reliable for diagnosis?
Oh, so I'm not an expert for Ancestry.com or 23andMe, so I can't speak to that. I would imagine that they probably have on their website some disclosures. It's my understanding that you cannot take information from something like that and have a diagnosis. It has to be what's called a CLIA-approved laboratory. So, what I would suggest if somebody found some type of gene change on one of those more broadly used databases, that you would take that information to your physician and have a conversation about what those findings might mean, and decide, mutually as a team if you wanted to go forward and get that retested on an approved lab. But I think, any genetic testing really requires a serious conversation between you and your physician about what you're going to do with that information. And then you really have to have an approved lab for diagnosis.
Great. Well, I know we're over on time. Dr. Dahir and Dr. Simmons, thank you so much for taking the time this evening on HPP Awareness Day to educate us and to share such important information about coordinating your personal care team. I think it was really helpful to hear from some that are doing it the best. So we really appreciate your time.
Well, thank you. We really appreciate the time to talk with you and celebrate this wonderful day. So thank you for your time and your organization of this great program.
Yes, ditto. Thank you all so much.